Good afternoon, everyone. We're just going to wait until the participants ticks up a little bit. We have a lot of people on here for our webinar. We'll be with you in a moment. Okay, good afternoon, and thank you for joining us for this exploration into common models of post-acute after-hours triage staffing. My name is Bernadette Smith. I'm your moderator for today's panel discussion, and I'm Vice President of Marketing for IntellaTriage, the leading after-hour triage service in the country. Today, we will be speaking about several common models of post-acute after-hours triage staffing. On-call nurses help fill in the gaps, but many organizations struggle with how to efficiently and effectively manage calls that come in after hours and lack the data to help to improve their processes. Our three most common models are non-clinical answering service, internal nurse team, and external nurse team. We will hear from providers who use these models in their organizations. We'll discuss the pros and cons for each, and even hear from a provider who's in the middle of a transition to a new model. This is an audience of hospice providers, so I have to tell you, oftentimes issues arrive in business hours when there are after business hours, when there are few staff members available. And there are some key trade-offs to these different models. And that's the second part that we'll be discussing today. When you're deciding how to plan out and strategize your model for post-acute, these are some of the trade-offs we talk about. When you think about it, 75% of the week is actually after hours. When was the last time you called into your own after hours team and experienced it from a patient or a family member's point of view? That's what we're hoping you think about today as you start to understand the different models available out there. Ask yourself, have I been thinking about this from the best angle? Do I have the best model in place for my patients, my caregivers, and my nurses? We'll discuss the metrics of where the impacts lie and what to consider. Before we get started, I want to call attention to the makeup of today's expert panel. It's comprised all of women, leaders in their fields and successful in their organizations. In our organization, IntellaTriage is working to drive change in multiple areas, including diversity and inclusion. To that aim, we were intentional of our panelist discussion. Panel comprised completely of women. With us today are Carla Davis of the LHC Group, Barbara Knott of University of North Carolina Health, and Lisa Schmitz of Common Spirit Health at Home. I'm proud to moderate this panel today, and thank you all for joining us. As a jumping off point, I will have each of you introduce yourselves and explain at a high level your current after hours model from an operational perspective. And then after introductions, we'll dive a little bit deeper into the nuts and bolts of your models. Two quick notes for our audience. Regardless of the three models that we discuss here, we do understand who is being staffed as the field nurse or the runner could differ by provider. So we're giving you the primary models, and sometimes that will change in your organization. For example, it could be a case manager alternating weekends or on-call staff taking additional shifts. We are just providing what's primary in the country right now. Also, please enter your questions in the Q&A chat available in the Zoom window. You can ask your questions throughout the entire discussion. And we should have some time left over at the end of our discussion to address any of your questions. I will be monitoring the box throughout the discussion, and will be able to interject if it's a time is of the essence kind of question. So without further ado, let's begin with Carla. Carla, will you tell us a little bit about your staffing model?
Thanks, Bernadette, and thanks for inviting my esteemed colleagues and I to have this discussion. I've learned a lot just in the practice sessions to about the models and thinking about how we should think about it differently. So I'm representing LHC Hospice today. I think most of you guys know that LHC bought Heart of Hospice last year. And so I'm going to talk about the Heart of Hospice model and where we are in the context of the overall LHC is that we're going to take some aspects of that and take it across the country. And we're sort of studying which aspects we want to do now. So we had a bifurcated model where calls for patients on service go one direction and calls for potential patients, referrals, go in a different direction. So I just wanted to mention that sort of high level. I'm going to be addressing the calls for the patients that are on service today, because I think that's what we're talking about. But I think it is interesting to note that you might want a different structure for patients who you're caring for and patients who you are not yet caring for. So for the patients that we're caring for, our model is we have a contracted non-clinical answering service, so number one, and we have a centralized internal nurse triage team, so number two. And then at the agency level, we have obviously the clinical team on call, and that model varies by the size of the agency. And this centralized model was put in place for about 1,700 patients in 16 different locations across 5 states.
Okay, thank you so very much. Lisa, why don't you talk about your internal nurse team?
Sure. And thank you again, Bernadette, for inviting me. This is going to be a fun conversation. So our internal call structure is supported by non-clinical. They are not contracted, but they are our employees. We call that the Star Center. Then we do not have an internal or a consolidated nurse triage group, but the external nurses, being they sit in the branch, then work the calls after the Star Center fields those calls. And unlike Carla, it's one pipeline: referrals, calls, patients we're caring for. So it's a lot coming into one spot.
Thank you. And how about Barbara? Tell us about your model, please.
Sure. Thank you, Bernadette, for inviting me. And I'm very grateful to be here. We use an outsourced company for our after hours calls, Monday through Friday and weekends as well. What our on-call services do is answer the phone as though they're UNC. We have not just hospice, but home health and our home infusion nursing program are also attached to this same company as an outsourced service. And the company will answer the phone based on where the call is coming from. They will say UNC Home Health, UNC Hospice, UNC Home Infusion Nursing, depending on where it's coming from. It's a registered nurse that answers the phone and triages and troubleshoots any of the calls that come in. The protocols are set up when we first contract with the service so that they are speaking and functioning the same as if it were one of our nurses that were answering the phone.
That's wonderful. Thank you very much, Barbara. That was great. So as we talk a little bit further about these different staffing models, some of the things we hear is about when escalation needs to occur. Who is doing that in each of your models? Now someone has answered the phone and it is determined that person who has answered the phone cannot handle the situation at that time. What happens next? Any one of you?
Sure.
Well, for us, with the
Barbara.
outsourced service, I'm sorry, Lisa.
No, that's fine. Go.
With the outsourced service, the nurse, as I said earlier, will try to handle any call that comes in. But we set up in our protocols what an escalation would look like. If a patient calls twice, you automatically call the nurse either in hospice or home health or home infusion. But we do still have a nurse that's on call from our agency, but it's only for answering escalations. It's not for answering any of the other calls that come in.
Okay. How about Lisa? Go ahead.
Sure. So and Barbara reminded me as that when our calls come in as well, they will press one for hospice, one for home health. The hospice goes to the top because since we're a home health and hospice company. And again, it goes to a non-clinical individual. So if it is patient related, then it is sent to the nurse at the individual branch. And so there's some struggle and connect there at times because the volume of calls that we're answering in the Star Center. And then there's wait time for that nurse to get back to that patient or that patient's family on that. So yep,
So how long does can that take, Lisa? Can that take quite a long time then?
Sure. It can anywhere from our average wait times on our call. The original call is 51 seconds up to 9 minutes, depending on the volume, depending on the time of day. Of course, we, after hours and weekends are what we're talking about, right? But we also have maybe staff calling that number every once in a while just to have something changed in the EMR. So yeah, the wait times can be long, and 51 seconds, 2 minutes, 3 minutes doesn't sound like a lot, but when you're talking a hospice patient or a family member that's uncomfortable, just extend that time in your head because that's what it feels like to them. So the wait times can be longer.
Yeah, we say that a lot over where we are, that we talk about, 3 minutes can feel like 3 years. It when you're really in the middle of something, with a family member or a loved one who is making a new sound or a sound that you're not familiar with, or, their pain has escalated to such an extent that length of time really does change how you feel significantly. Yeah. How about you, Carla? Can you tell us a little bit about how you handle escalation?
Sure. Well, on the length of time thing, I think too, we realize that they don't call until it's gotten to the point where they felt like they had to, so that, they've been anxious way before they actually picked up the phone. So I agree with that. And our model, the non-clinical answering service that's external, passes on every patient care issue. So not like if it's an employee, having a question, every patient care issue to our centralized triage. The centralized triage staff are staffed according to the day and the call volume that we historically have experienced. So it may be 2 or 3 nurses on call. And their role is to try to handle it if it can be handled well over the phone, or to get something started with the patient and family while the nurse on the ground is hitting the road in transit to the patient's family. And so there are a lot of calls that they are able to handle. And so the only time the nurse on the ground gets called from triage is if the centralized triage could not handle it well, and they need to have somebody in person. And we also have standards around when visits need to be made so that we are consistently handling that across all the triage nurses. And so they escalate it to the nurse on the ground. And I say nurse, but I think another part of our model that might be a little bit unique is that we have psychosocial on call, we have a manager on call, I have a salesperson on call, and I have aides in most of our locations on call, because the calls don't always need to be handled by the nurse. And I think, in today's day with the nursing shortage, anything that can be handled well with a non-nurse, and maybe even better, right? If the issue is really the anxiety of the daughter, then that would be better handled with a social work visit, right? Or if the issue is the patient soiled themselves and the caregiver can't change them, then that issue would be better handled by the aide. If the person on the ground, usually the nurse, isn't able to resolve the issue, or for some reason we can't contact them, or they refuse to go, or something like that, then it is accelerated. Triage knows to accelerate it, and we have certain timeframes for those things, to the manager on call.
Okay. Am I missing anything on this? Yeah, go ahead, Barbara.
Bernadette, I just wanted to follow up, to add to the call, the answer time. With our company, the company that we use, it's 35 seconds is the average time to answer. which has been wonderful. We have had people say they've never had anybody answer the phone as fast as they do, after hours. So they call after hours. And we do get staff calling in to call out sick. And we do have patients calling in to ask, what time is my nurse coming tomorrow? And the triage nurse handles all of that. None of that gets escalated. As Carla said, you'll have people call just to call sometimes, and they do take care of that. Our average talk time for the nurse to resolve an issue is less than 3.5 minutes, and we don't see those calls. So we've been pretty satisfied.
Wow, great. Thank you for sharing that. That's great. I do have some questions that I think make sense here that are coming in from our audience right now. So before we move on to the next slide and talk about the trade-offs and when we start to choose these models, I'm going to choose a question here. For Barbara, the question was, I imagine you did a cost analysis. Oh, no, I'm going to save that one for the next slide. There was one here that I thought was important. Using the answering service, does that company have access to your EMR? So that would really be for Barbara or a little bit for Lisa.
Yes, absolutely. During the setup, we had gotten all of the nurses. The company does have access to the EMR. And what happens when there's turnover at the company, which happens everywhere, those new people, we've even given the company the access to request new staff access in our EMR. So they're able to do that on their own. I, of course, am notified when someone new is getting into the system, and I do go in and approve it, but that is managed completely by the company. And one of the things, just to expand on what I said, is when there is turnover at the company, that's one of the many reasons that we decided to outsource, because when there's turnover at the agency, at the hospice or home health, I'm not now scrambling for who's going to cover call. Now we have to spread on call out there'll be less days among the staff that we have until we can replace that person. It's not my issue. On call is not my issue. It becomes the issue of the company to make sure that we're covered. We're just covered every day. So the only time I ever know that there's an issue at the agency, or not even an issue at the company, but that there is any turnover, is when they need to access the EMR for a new employee.
That sounds like a nice relief for you. It really does.
Major relief.
I believe it. Carla, with an entire team on call, is there a stipend there, or is it just described as an expected task on hire? And I guess that could go to you, Lisa, as well.
You want to take it, Carla?
So you're talking about at the agency level?
Yeah, this is a question that came in. Yep.
Yeah, it depends on the role. So, and I don't know if I'm going to go into all of the details on that, but it depends on the role. Some of it is expected, and for the clinician, the interdisciplinary team, that we certainly pay them to be on call.
Okay.
Yeah, that's the same with Common Spirit Health. If we have an administrator on call for those things that need to be escalated, and there's money attached to that, and then of course there is on-call pay and different things, and then if they go over, because these are, now keep in mind, these are nurses and other clinicians like Carla and Barbara said, social workers, aides that are working during the week too, right? So they're when they're out after hours, weekends, they're producing and receiving also productivity bonuses because they're going above and beyond. So there's cost related associated to that. So
Okay.
Yeah.
Okay, thank you. One last question while we're on here, I wanted to ask both Barbara and Lisa, Lisa, I know you're in the middle of a transition, actually, and Barbara, you have made this transition over to an external nurse team. So can you talk a little bit about what the catalysts there were? What was the ultimate tipping point and said, we can't handle this internally all the time anymore? Can you tell us a little bit about that?
Sure. We had the traditional model where staff worked during the day and then rotated on call at night and on weekends. What really was the catalyst for this was our inability to hire nurses because they had to be on call. We heard time and time again, I need a work-life balance. I need to be able to go to sleep at night and not worry about answering the phone, about being awake all night. Because when you think about the kinds of calls that come in on call, and I just said it, what time is my nurse coming tomorrow? You know, those kinds of calls. And a nurse doesn't want to have to be woken up to answer that kind of a question. So that was what made us first start looking at it. We had 6 nurses in a row for our hospice about 2 years ago, a little over 2 years ago, that we had made offers to. And then when we talked about on call, each of them backed out. So it was 6 nurses in a row that, because of on call, would not come and work with us. So we started looking at it. And when we looked at an outsourced company and then started talking to even the staff nurses that were there, what would you think if we did this? There was a resounding, oh my God, you mean I can sleep at night? You mean the only call I get will be a call that, you know, for hospice specifically, I'll have to go make a visit because somebody died or something else happened. So there wasn't a lot of reason not to continue investigating this type of service, and we've never looked back.
Okay, thank you. How about you, Lisa?
You know, a lot of what Barbara said, we start looking at that, but we thought, you know, to grow, we need to do something different and not the same model as we've done for the past 20 plus years. Right. So, but it really came to a point during our voice survey. It's called My Voice Survey. And one of the questions was about well-being, and top 2 things that came back, or top 2 lowest scores, I think the lowest ones, is I can enjoy my free time without focusing on work matters. And then my work leaves me emotionally drained. That was a big one we focused on. And when we did our town halls, our listening sessions, what we found is the call, and they're working during the day and then not being able to turn that off. And I don't have a specific number like Barbara was 6, but I know across my region in the company, we've lost nurses because of that call requirement. So yeah, I mean, we just are trying to help work-life balance, personal, professional balance, and that well-being piece, which is really important to us, and leaving us emotionally drained. Because if they're emotionally drained and working in hospice, and I'm asking them to go out to that patient, I need to have them have something, some energy, something to take with them. And so that's why we started looking at how can we do this differently, support our staff, and at the end, better outcomes and experiences for our patients.
Bernadette, I mean, I think
Yeah.
for us, you know, it's the same decision, whether it's internal triage, essentially the same, you know, as they have mentioned. But in addition to that, like, it helps me to sleep at night, to know that we are handling these situations consistently across the agencies, no matter what size of an agency, no matter what resource, that we are driving consistent quality and compliance and how we're addressing each of these issues. And you may have an agency with a new nurse on call, and this way, at least I know that we are meeting our standard of quality care.
That's great. Oh, sorry. Thank you all so much for sharing about that. Those are really insightful thoughts. Let's move on to, as we help our audience understand more about how to manage this, let's talk about what some of the trade-offs organizations are thinking of when they're trying to strategize this, when they're trying to move forward and change their model or stick with their model and improve upon it. So some of the trade-offs that we've found are listed here. Employee satisfaction, which we've just spoken about a bit, cost, which we also tackled a tiny bit, but we didn't. It's a question and we're coming back to it in a moment. Control, growth, which we did discuss, and patient experience. So let's begin with employee satisfaction and talk a little bit about that. I'd love to hear a little bit further if anyone has anything further that we haven't touched upon so far, that you're deciding between models or that's helping you determine where you want to go with that. Anyone have anything further to share?
I guess I just kind of said everything. I jumped
You
ahead,
did.
Bernadette. I'm sorry. It's like, dang it.
That's right.
But yeah, I mean, it's just that well-being piece. It's just that well-being piece, and being a nurse myself and doing call myself in the past years, even if you do not receive that call during the night, it's that chance you could that weighs on you. And I get when they're saying, I know I have only had X amount of calls this week, but just not being able to leave work behind. So that's really the big part for us by trying to look at doing something different.
Sure.
And
Sure.
I
mean,
agree
some of the
with
things,
Lisa.
yeah.
I
Yeah.
agree with Lisa. There's really nothing more to add to that,
Mm.
that the nurses are very satisfied.
Great. And that's some of what we're hearing too, just with our clients across the board. We all know the idea of the staffing crisis that we're all undergoing right now. And it's another way to improve employee satisfaction and up your retention rates, which is really helpful across for so many reasons, right? We all know and let's move on to that, right? So if we moved on to cost and what that does, the loss of a nurse can be somewhere in the range of $40,000, just that side alone cost, right? The attrition cost itself. So that's one thing that we know that people think about. What are some other hidden costs in addition to that? Recruiting, maybe auxiliary costs, administrative burden. Have any of you experienced some of that you that helped you just determine one way or the other what your model might look like?
I think it was the turnover piece. I mean, it was all of that, right? So
Mm-hmm.
it was a turnover piece. And I believe that we attached like 15,000 per client per staff that went. And we looked at if we could just reduce our turnover and bring it down by 20%, that was a significant savings of like upwards of 915,000. So and that's just turnover. And that doesn't include, recruitment cost and maybe sign-on bonuses and different things like that. And if you go to, as we looking at a different model, then there's that savings of the on-call dollars that we mentioned at the top of the call, and those bonus dollars that I had mentioned. And so that can be, depending on your size, that can be a significant savings to your bottom line that can be put towards better wages and attracting different staff along the way. So yeah, there's that. And then of course, administrative costs, like I had said before, there's a lot of it. And then the business that maybe that nurse is tired that you didn't get, but I think we're going to talk about that in control. So see, I jumped ahead again, Bernadette. I'm sorry.
That's okay. This is it's controlled chaos, right? We're working towards it. We're hitting all the points we need. We're educating our audience, so it's quite all right. Anyone else want to speak about cost while we're here?
Yeah, I do, because I think, again, whether you're doing it centralized internally or contracting it externally, you end up with an expert at this thing, right? Triaging or handling these calls and that come in that have a variety of different things that go wrong that need to be resolved is a special skill. And you can't always afford that special skill unless you have a more centralized or external specialist model. So if you're a small agency, you could not afford to have a full-time on-call triaging team. You couldn't afford it. But by contracting with companies like yours, or by centralizing it, if you're large enough and fortunate enough to be large enough that you have enough resources that you can pool them together, you can get people who want to do that job and are very good at doing that specialized job. And I think that's important because it isn't the same as case managing. But in case managers manage triage position, it's a different job.
Right. You're absolutely right. When we train our nurses, we have experienced hospice nurses. We train to do triage, which is a very different thing. We're not training them how to be hospice nurses. They already are that. They've been that for a while, and you have to train them to perform a different job and be experts at that. And you're absolutely right, Carla. That's a big piece of the puzzle right there. Absolutely. Anyone else have anything they want to share on that?
I do. When we outsourced, we absolutely increased our cost. But we weighed that cost, because before, when it was the traditional on-call, we had an answering service that we paid maybe $1,000 a month, who would put every single call through, no matter what time of day or night it came through. But when we looked at the cost of an increased cost to have a home health or hospice trained nurse answer every single phone call that came through that we did not have to worry about. The calls did not come through to our nurses. As Lisa has said, work-life balance, showing that we care about our employees and their well-being, our ability to hire staff. When we first moved over to the outsourced company, we started putting in our ads for nurses, modified on-call program. And that's what brought us a lot of interest, is to talk about that modified on-call program. We explained it and we were able to hire people. Our turnover rate in 2018 was about 40%, and that's for home health and hospice together, outrageous and unsustainable, you know that. And now now for 2021, it was down to 15%. I wish I could say it was all because of the on-call. It isn't. We've done a lot of work, but it certainly helped. So I'm also a believer in you get what you pay for. And we have not at any time, even our finance people have not ever pushed back when they've seen the results that we've gotten by not having to worry about on-call, not having to hire on-call staff, not having to look at turnover and have people doing more on call because we've had the turnover. They don't even push back anymore at this point, and that's big.
That is, thank you. One of our audience members did ask, Barbara, did you do a cost analysis of external triage versus internal nursing triage? I think you have answered that question. So Lori, if you want to, type in and let me know if I think that's been answered at this point. So if not, let me know. We'll dive deeper into Barbara.
Can I add?
I will say, when you talk about
Sure.
a cost benefit analysis, I don't just look at pennies to pennies. It's also the intangibles of the staff and the benefit to the staff and the benefit to the organization. So we did not do a pennies to pennies analysis, because if that was the only analysis we did, obviously we would have kept everything internal. But we do not regret ever going to the outsourced company.
Thank you.
Just
Lori.
gonna
Go
add
ahead,
to-
Lisa. Oh,
No, go ahead,
Sorry.
Carla. No,
We're all
Carla,
talking
go.
about- So if you have high turnover, ironically, it increases your calls,
Mhm.
which increases your cost for on-call. So it's like, it is hard to
It's
do pennies
circular.
to pennies, because you have to think through all of these things.
It's a really
Right.
good point. Really good point. Yeah, they definitely weave with each other. Absolutely. Lisa,
we
did you want to
talked-
share?
Yeah, I did. You talk about cost, but we can also look at what our revenue gains are, right? So by switching and looking at your models differently. So for us, we have nurses that are dedicated to the weekends or to after hours. We have maybe 7 on, 7 off each branch, each area. We do something, not that we started out to do something different, but as the nursing crisis really hit us, you hired what people were willing to do. So it's like, okay, you're willing to do 7 on, 7 off. You're willing to do Friday from 5 to 8 a.m. on Monday, which is 63 hours, by the way, right? So we looked at the nurses that are doing those specialized, and going to a different type of model means we're gaining RNs that will be patient facing, case managers, not triaging, and being able to serve more and bring on more patients. So there's gains too in there. So you want to look at your gains, what you will harvest by looking at different models.
So I guess you're attracting different nurses that can work now at the top of their license because you're doing something else in another way.
So no, the nurses that we're currently using for our current model, say weekend warrior position from Friday 5 p.m. to Monday 8 a.m. As we move into a different way of supporting after hours, then we'll have these nurses that we possibly won't need to fill that role any longer, right? And switching them to a patient facing and utilizing them more than just the triage, but case managing, doing starts of care, and like I said, serving the community more. Does that make sense?
It absolutely does.
Okay.
Yes, thank
All
you.
right.
I'm glad we clarified that. Great, thank you.
Bernadette,
all right, let's move on.
Bernadette, I just
ahead.
want to add one more thing as it relates to cost. Is What we've also benefited from is, every organization has to have staff meetings, big team meetings, and there always has to be one or two people answering the phones in case patients call in and interrupting nurses in a meeting because it's a patient on the phone. We have the ability to use the outsourced triage company to work with us during the day and answer all of our calls. We just forward our phones over to the company. They take all of the calls and then give us a report at the end of the hour and a half of the meeting. So that was another cost that we thought was worth it.
Sure, yeah, that's an added flexibility. Thanks for sharing, Barbara. Great. Let's move on to control and talk about it's scary, right? The idea of losing control if you're outsourcing, and it's actually more comfortable, right? If you're hanging on to and hiring, and you have your internal staff. And it's the same way that what Carla's been speaking about, the idea that she has consolidated A, and B, the word's not coming, but this. Can you help me find that word, Barbara, Carla? The same word, the same practice from one.
Standardized.
Thank you.
Consistent.
I was drawing a blank. I'm sorry.
It wasn't coming. It's okay. But she standardized her system and her protocols across her different agencies and locations, right? And that is what, when people are thinking about these different models, is trying to understand there is some loss of control, or they really want to hold on to control. Can you, any of you, speak to that and how you've managed that in some ways?
I'll tell you that in the beginning, we were worried. We don't know these nurses. We have not trained these nurses. It's purely a, I'm going to just fall and you're going to catch me kind of moment. But we kept a very close eye during the implementation period and during the transition on how calls were being answered. Reports are checked. We get great reports on every single call that comes in, how it was managed. If there was an issue during the implementation where one of the nurses may not have exactly followed the protocol as we set it up, we spoke to our representative and it was corrected and it wasn't an issue again. And we learned to trust. Giving up control is difficult for anybody, but it was a learned trust that the company gave us. And that's also not something easy to get when you outsource, is how do I know? How do I know? So they proved that we were able to take a breath and we were able to trust that the call would be handled as though it were one of our nurses handling it.
Great, thank you. Lisa or Carla, anything you want to add there?
Well, control, if there's any of Common Spirit Health people listening, they'll crack up. But control is something that I struggle with, but if anything else, not lack of, but needing it, the pandemic, right? The pandemic kind of took the control away from us, and we had to adapt minute by minute, hour by hour, day by day. And that is where I'm, as we talk about doing a different model, I'm okay. The control part of it, our staff is tired, leaving it in their hands after hours and weekends, administrator after hours and weekends. They're okay to start sending it somewhere else, because they learned through the past 2 years with the pandemic, we've had to give up control, and it worked out. And we were okay, and we figured it out as we went. So I'm more worried when I have people that are saying they are emotionally drained, that they don't have work-life balance, that they're tired, they don't know when they stop, when they start. I'm worried about that, and trying to give them that gift of, you know what, we got this, go refresh, renew, recharge, and we'll see you tomorrow. So that's what I'm looking at. That's how I look at control.
Yeah, I think the same for us. It was probably a little bit less of an issue because they were heart of hospice nurses that were known in the organization, maybe not from their location that we centralized. So a little bit less of an issue, but the benefit so outweighs the loss of control. Now, you want to see people get anxious about losing control, you centralize your referral to admission process.
Oh, yeah.
that people get really anxious about.
Yeah, that's true.
But still, I work through those issues too, because the benefit outweighed the burden ultimately.
Sure, absolutely, right. And that standardization, right? You have your protocols in place, you know what to expect. Everyone knows what to expect, and that helps with that issue as well, I'd imagine. Let's talk about growth. So one of the questions here is someone would like to know about how large your agencies are. We can talk about your ADC, and then as we talk about your ADC, maybe you could help us understand how your model of after hours triage has aided in your growth and or not. Carla, you want to start?
Sure. So we have all different sizes of agencies, from 35 patients to 235 patients that they were supporting. And so again, I think that centralizing it allows the baby agencies to be able to breathe, because the nurses don't have as much responsibility after hours. And so it absolutely supports growth. But I think the other concept with either of the two models that we're talking about, as opposed to doing your own call for each agency, is that it's scalable. And it helps you to be able to not just grow each agency, but roll in. We did acquisitions, we did de novos, and again, roll it into triage. And we have a certain model for how much they can handle, but roll it into triage. And again, from the beginning, it helped support the success of the growth, because I knew we were achieving this consistency across all of the agencies.
How many, you might not know this answer, but how many calls does your triage team field on a weekend morning, let's say, maybe?
I cannot answer that question.
Sorry, I threw that at you.
Okay.
Never mind. How about Barbara, you want to go? How large is your ADC?
Sure,
and maybe
sure.
You can answer that.
So with home health, hospice, infusion together, it's just a little bit under 1,000 patients. And when I think about growth, I think about in our businesses, growth is only dependent on staff. So if we're able to hire staff, we're able to grow and accept more referrals. And we've been able to do that without having to add nurses to on-call, to have them know they're going to do triage. In the month of February, our service answered 445 calls. So that's just about half of our patients called in during the month of February, which was, a short month, and they were handled. They were just taken care of.
Oh, that's great. Thank you. Lisa, anything you want to add?
No,
how large is common?
So our ADC, our branches vary from 40 to the largest one being 389. And then, but that's hospice, if you include home care, our total census, hopefully my bosses aren't listening, I think our total census is like 12,000, 14,000. We all lie to each other. 15,000. No, it's about 11 or 12,000. And so, like you guys are going to go check, but yeah. So we, for the month of February, and I'm looking for that report and I did find it, we had like 2,200 calls between home care and hospice that were escalated, that needed a nurse. And then they're broken down into other categories. I just can't find that report in front of me right now. So yeah.
Wow. Okay, thank you so much. Thank you both, all three of you. All right, let's move on to our final key trade-off, or something that people think about when they talk about their after-hours model. And let's talk about the patient experience. And on our next slide, we'll talk about some metrics, and we'll help people understand what to think about as they move forward. But can anyone speak to that, how their model has improved or led to a lesser patient experience?
I can tell you that in our patient satisfaction, we don't necessarily ask a question about on-call, but we do have comments that patients always provide. And I can tell you that not once has there been a complaint about calling after hours, about trying to reach a nurse after hours, on weekends. and I really think that's because the nurses answer the phone as UNC Home Health, UNC Hospice. So patients believe they're speaking to one of our nurses anyway. So it's not been an issue for us as far as I know.
Great, thank you. Anyone else want to share?
So the patient experience, maybe the inconsistency a little bit, we'll get some feedback about that. So the nurses that work during the day, the clinicians that work Monday through Friday, traditional hours, are those individuals that will be covering after hours, weekends, but so there's just that inconsistency that we'll hear every once in a while. And the timeliness, I think I said that being the initial call anywhere from 51 seconds to 9 minutes. And then that's just to speak to our non-clinical person and then get it to a clinical person. So that's some feedback that we've received that we've been trying to correct.
Okay.
So
Carla?
I'll just chime in from our experience, the contracted external non-clinical answering service, we do receive complaints from because they answer for all kinds of businesses, and obviously our care is very special and unique. And so that is a problem I'm trying to solve for now. Once they get to the centralized triage nurses, the patient experience is fabulous. But the other thing that I thought I would mention about patient experience that supports specialized, either centralized internally or external experience is that you have oversight of how the care is being delivered during the day by the kinds of calls that are coming at night.
Mhm.
And if you delve into that and categorize those calls, you can start to solve problems and improve the patient experience, whether it's the clinical staff or not doing something. And I just discovered that in one of our locations where we were able to look at the aggregated data and nail down a particular situation. Or your DME partner or your pharmacy partner or whatever. So we have, and I know you're going to get to this later, but Lisa's been cutting ahead, so I'm going to cut ahead again. We have categorized each type of call into buckets so that we could analyze it from a quality improvement perspective. And that improves the patient experience. And you can't do that as easily if it's all separate.
That's a good point. If you want to know
Yep.
the health, if you want to know the health of your agency, in my opinion, look at your after-hour weekend traffic and ask different questions, and that'll tell you the health of your agency and where your areas you need to support.
Yeah, agree to hop on that. And it was a little bit jumping ahead, but who cares? The idea that a lot of our clients do use that almost as a copy experience, right? They're understanding exactly that. Why is your patient running out of DME on a Friday night or a Saturday morning? That should have been checked out ahead of time. What are you not, what are you missing during your visits during the day? So absolutely correct. That's we're hearing that a lot across the board. Same idea. Okay, let's move on to our final part of our conversation. What we're going to talk about here is the idea of what we would like our audience to consider. And we kind of put it all in one speedy little slide. What to consider when you're choosing your after hours triage. So you're going to talk about your speed to nurse. We did talk about that as we've been going through this conversation, and we've heard anywhere from 35 seconds to 9 minutes. And we know that 9 minutes is going to alter the patient experience. And that this is, just as Carla said, a really specialized patient base here that we're working with. That's something to think about. IntellaTriage does a really good speed to nurse, just so you know. The next thing we want to think about as you go, hold on, I will tell you, I'm going to move it forward a little bit, is your speed to visit. So if you are in the same way that we've been talking about sooner, the faster you get to a nurse on call, the faster that nurse will be able to triage and then decide if it's time to escalate. And that's a really important factor to factor into your decisions as you're working through your after hours triage. If you're going to use model A, how will you measure your speed to nurse and how will you measure your speed to visit? Does anyone want to weigh in on either of those two things as we move forward on this?
No, I think we've kind of covered that unless there's other questions.
No, I think so as well. It's kind of a follow-up slide. Also, first call resolution. So as you start to decide what to do here, has the situation been handled under the first call, or do they have to call back? And how often? So if you're monitoring your internal measures and understanding what's happening, that's a very important piece of this puzzle as well. Do they have to call back, or does the nurse that is answering, that is triaging that call, do they follow up with you, with the patient? Biggest employee dissatisfiers, that has come up earlier in this call as well, in this discussion, and the idea that you have to be on call all the time, or your work-life balance has taken a hit because you are on call, or you're not able to turn it off when you leave work. So that's a big part of the discussion. And it's also something to think about when you're making this decision, because as we all know, we're in the middle of the Great Resignation. There is the nursing crisis has reached disturbing proportions at this point. And so we really want to work to keep our nurses engaged and happy. And then the RN turnover with the after hours team. I think one of my notes here says something to the effect that the after hours nursing turnover in the industry is between 40 and 45%. And that's huge. That's a really big number, especially if we're talking about, we think that the attrition cost of that is $40,000. So you really need to keep in mind all these things on this list. And then you need to take a look at what your CAP scores are and how these different factors may or may not affect your CAP score. So I put up the national averages here just to keep keep us honest here in this conversation. Does anyone else have anything they want to share before I head over to questions? We do have some Q&A here.
I think the one thing I would point out that I just listening to you today, Bernadette, was that triage education piece, right? That specialty piece. It's, I don't know if it's quite like an ER nurse, ED nurse versus a med surge, but it's a different thought process, right? So we may have strong case managers, really great admission clinicians, but triage is maybe not in their wheelhouse, although they triage and deal, problem solve with their patients every day. But I really like that point that the
pace is different though.
Mm-hmm. The pace is different. You're right.
Yeah.
Right. And especially if in the same way, if it's in a centralized location, right? So now you're answering, your pace is much quicker. You're used to answering 3 calls a night. Now you're answering many more calls a night, and you're trying to understand, what the patient and or their caregiver is experiencing in that moment, and you're doing it over the phone, and you're trying to nurse to that. And that's a difficult thing to do. It definitely takes its own special set of training and special set of skills. Agree. Absolutely right. Okay, let's move on to the Q&A. We have answered some of these questions as we're going, but let's move on to David Dowd. He says that we're a small hospice agency. Can you recommend a phone service that you found helpful for on-call? For example, rolling calls from one internal employee to the next if the call can't be answered by the first person. It's been a huge challenge for them. And that kind of goes back to the idea of who does this make sense for? And I believe it was Carla who spoke about it earlier, the size of, if you're small, it makes sense because you can keep control over what's happening. And then as you get larger, it's a little trickier. So with a small hospice agency, does anyone have a service that they might recommend for something like that? Or a best practice?
Well, I think his idea of how you set up the phone structure, because that's not something we've talked about really today, is important. And there's a lot of technology that can support whichever model you do better. And so we do have a phone system that automatically rolls at certain times and certain days. And then to the triage team or to the agency, it's also set to cycle through, just like he was suggesting. So I think that that's important regardless of which model you use.
Yeah, that's how we roll it too. I mean, obviously we're not a small hospice agency, but we do the exact same thing. So we have a small team dedicated to whichever agency that we're working on that evening. But then if for some reason the call volume is so extreme, there is a secondary team that it rolls onto. So it hits every person in that team before it rolls onto the next team. And it is, once again, still a clinical, a registered nurse there. But for that reason, to make sure that you get, that the call doesn't go and it doesn't go unanswered, A, and it doesn't take too long to answer, B. How about, is this, I guess this looks like this might be, it could be for any one of you. Is there a different staff that ultimately go out to your regular daytime staff when they get called out after the answering service escalates it? So we did kind of touch this a little bit, but any one of you might want to add to that. So Megan, just so you know, generally, yes, the after hours triage does answer it. And then when it's time to escalate it, there are still on-call nurses, and those are the people who will do the visit. Does anyone else have anything to share about that?
Just like everyone said, the model depends on who you can find and how large your agency is and how geographically spread out you are. I think that
Right.
what layers you have on call and how many people you have on call, it has a lot of variability.
Absolutely right. Agree. Is there a reason that RNs are preferred for after hours as opposed to LVNs in terms of cost? LVNs would shed cost and can perform or pronounce a death just in the way an RN can. Does this speak to the COPs? Does anyone have the answer to this?
It is a COP. I don't have the exact COP, but an RN needs to take that first call. LPN, LVN cannot triage. They could be your runner. The RN could triage and decide, and then the LPN can do, and we will do that. I think of them as our rare library book. And if they want to send out the LPN, they need to check with their administrator on call. But yeah, that's my understanding. Barbara, Carla.
Right. Oh, I agree. You know, I think it's also a state law, not just federal. LVNs cannot do assessments. And we want the triage nurse to assess that patient to understand what's happening and whether or not a visit needs to be made.
Yeah, I agree. It's very state specific about how what their standard of practice is. But we have experimented with RN LPN teams in some of our agencies, but not the triage function. Triage has to be an RN, but there are definitely opportunities to use the LPN, LVN on call. And I think as we're again facing this nursing shortage, we're trying to think about all of these things differently.
Right, sure, absolutely. Okay, next question, which I think I have an answer, but maybe either one, any of you could weigh in. So do you have an idea of what size it makes sense to do it yourself internally versus externally and outsourcing? And what we have found that works for a model is somewhere in the 65 to 75 average daily census, or ADC, range is what makes sense from a cost perspective and a control perspective. It just has to do with the number of calls you're getting in, and at certain, once you kind of surpass that 75, you're often getting a lot more calls, and that makes it a lot more difficult to manage. Has anyone else had any different experience from that?
No, I mean, from a cost experience, Bernadette, no, but from our length of stay dropping, I'm sure everyone's experiencing in that churn, admit, discharge, some after hour weekend support. I've been seeing like the wheels come off the bus a little bit around 45, 50, and even 60, because it's a faster pace as we see that length of stay. So cost wise, I think you're spot on. I think stress wise to our staff in the field experiencing that higher churn, it's probably a lower number. I do not have any data to support it. That's just my opinion, but that's been my experience as well.
That's a really good point. That's a really good point. Thank you, Lisa. I think those are all the questions we have for today. Is there anything else that anyone else would like to share? Or Any questions I may have missed or any topics I may have missed in this conversation?
No, I think we've hit it. I just really enjoy Carla and Barbara and you, and thanks for inviting us. You know, probably more Barbara than Carla. No, I'm just kidding. I'm just kidding. Oh my gosh, I just met Carla. We tend to do that. So no, this has been fun. This is, after hours weekends has been always something I've solved since I've been a nurse, right? In long-term care and now hospice home care. It's just something that and I'm just trying to solve and support our staff and our patients all at the same time.
Yeah, we understand. And that's what we're here to do, right, at IntellaTriage. I just wanted to close out with some basic facts that we have found. Nurses experience burnout. Generally, they won't provide the same high level of quality care. I'm not sure that we touched exactly on that, and I wanted to make sure that we focus on that a little bit. And that, again, as we said, it does lead to lower patient satisfaction. So maybe that's why the DME hasn't hit, right? Maybe that's why you have to go back and re-copy, and it's the same exact conversation that we had earlier, where it spins and spins and spins. Well, if you're experiencing the burnout, you're likely not providing the same high level quality of care. So that's an important thing to think about when we talk about your RN turnover and your employee dissatisfiers. Also, we might want to understand that when we talk about what your first call resolution is, at IntellaTriage, we average around 70%. So if you are in that range, you're looking good. And if you're not, it's something to review and move forward with. So I just want to make sure we hit that number. There will be a recording available after this call. So you will receive it from Hospice News and the Staffing Summit in general. My fellow panelists, I want you to know that we just got a reply in here that said we had a fantastic panel today. So high fives across the whole way. Thank you, all three of you, for joining us today. It was really wonderful. I'm going to skip past this question slide because we already did it, and say thank you once again. Our contact information is here on this slide. You can also get it from Hospice News. And here is some special resources you might find available on the end of this slide, and you can also find it in the Q&A panel as well. So thank you once again, Carla. Thank you, Lisa. Thank you, Barbara. This has been wonderful, and I hope you all have a wonderful day. Thanks.
Thank you.